the rest will catch up. So I have to do the disclaimer that I don't have any conflict of interest, and these are certain things which we have to cover. So we'll start with this slide, and I don't know if you guys can guess which one is which. Any ideas? Let's start with which one you think is the right match. Take a guess it because we are going to talk, because this is like sometimes what they do in boards. I have seen a question like they give you 4 PO2s and they want you to see which one is the uterine artery. Take a guess. Like what's the rationale behind this question? What I'm thinking to make sure that you guys know the difference between different PO2s and different vessels. Anyway, let's take a guess. Komal, can you take a guess? Which one? Uterine artery. Which should be the one? Yeah, you can take.
Because the highest level should be uterine artery because blood come through.
Excellent. So let's do that. So Satya said that this is the highest one. Good. Now we are left with uterine vein. Which one?
Which should be the
Take a guess.
artery. Lowest.
Lowest is umbilical
No,
artery.
the
So
umbilical
let's go
vein
one by
should be
one.
next.
Sorry, Komal. Which one is uterine vein? 1, 2, 3 on the red. Top one, middle one, third one.
The 40 to 60. I'm not Komal though.
Oh, sorry, sir. I apologize. Okay, good. So this is it. Then this is the umbilical vein, and you are absolutely right, Satya. You got the concept that uterine artery should be the lowest. The concept behind it is
Uterine artery.
exactly is the highest. Exactly. And veins are in between. And I have another interesting slide that explains it very well. Okay, good. So now let's go to the next slide. This is very important slide because this will tell you the understanding, like how the uterine artery. See, the uterine artery is on the arrow. So this is the uterine artery. This is the umbilical vein, and of course, I'll run the animation in a minute. But see how these pressures and all that changes. So let me run the. So see, oxygen goes here. This goes to the umbilical vein, and then the whole process, the fetus get this metabolism done. It goes to the umbilical artery and then comes back to the uterine vein. So the clue here is just remember, in after birth, uterine artery has better hood. Before birth, venous has more hood. This, if you have that concept, nobody can really make you feel bad about it. Now you see a red dot here at umbilical vein, and see the PO2 is only 30. So my question is, this PO2 is very low. Like mom has a PO2 of 120, 100. So it's almost 1/3. So how do the baby fetus then make it up for that? You have to come. Nature has to compensate. If they are giving me low PO2, I should be provided with some gadget to make it better. So what they have a fetal hemoglobin. So fetal hemoglobin really binds it very fast. So, and I'll show you that concept. And sometimes they ask you in exam, what is P50? So if they ask you what is P50, easy to remember, you know, the PaO2 where the saturation is 50%. So as you guys can see, 2 graphs. So if your curve is shifted to the left, of course your PO2 is different, P50. So this is very important. If it's simple question, and I've seen people missing in the exam. Oh, you know what? How did you do this question? Which question? Oh, they asked P50. So a very difficult question. No, not difficult question. They were just asking. You just have to put an arrow from 50 and drop it down. Where it comes, that is the PO2. And this comes as a calculation question, and you can get 100% out of it just by knowing it. So anyway, so now let's go back and see how this P50 works for umbilical vein. Let me do an animation. See, you got this point here, and then for 30, look at the saturation. So even with the PO2 of 30 with the fetal hemoglobin, which is the blue curve, you see it's almost 80% is saturated. So you get a big advantage when as a fetus. Any question on this slide? No? Okay. This is just to show that how, that's what I tell my students, that please do call your mom at least weekly and thank her for providing all the oxygen and nutrients. Really going through so much. So see, mom inhaled about 150, and by the time it reaches the placenta, and on the picture on the right, it's a busy slide. And of course, you guys have access to the video. You pause it and see. But the basic idea, which I want to say, that look at how the oxygen from the air comes down to the baby, and baby only get 30, but baby survive with that because of the fetal hemoglobin. And this is the article reference if you want to take a detailed look. Another animation, and you guys know it already, but just to walk you through, keep looking on the white dots, these are oxygen, and see how the oxygen goes. And then, so you guys know already that in fetus, the circulation is different than the newborn. And how we know that? This is the comparison. You see how thing changes after birth? You guys have seen this picture many times, but just to show you, you guys already know it. So now this is interesting. I just found out that the new NRP course would have a cardiac component to it now. So you have to do, they are adding a chapter. So you can, like, I think paid what, $30 or something. I haven't done anything yet on this course, but then they walk you through every step. I think they have realized that how important to understanding cardiac physiology. The reason I'm putting it here, because my few slides are going to be on this concept that how heart, oxygen, lungs, everything works together. It's not like you can just learn one and let go the other. So oxygen is a drug, but drugs have side effects. So what are the side effects the drug has? Oxygen toxicity. And this is the thing that oxygen combines with ultraviolet rays, and then you have super radicals, and then nature has provided antioxidants, but premature babies don't have these much antioxidants. So even giving a little bit of more oxygen can cause them going through this cascade of producing free radicals. And this is the big list. Again, like I said, you don't have to remember everything, but all are related to that. Intraventricular hemorrhage, PVL, chronic lung disease, ROC, everything has something to do with oxygen-free radical injury. And on the right side, you have a picture saying that. Of course, early in my career, this is 1998. So what I looked at, there was a study done to look at the transfusion load, and we calculated exactly how much the baby get the blood and how much iron is there, and we published it. So just to show you that how you can capitalize on an information, and it was very easy at that time to publish. It's very difficult to publish because the moment you Google, there are like 7 articles already on that. In 1998, if you come up with any idea, oh yeah, fine, just send it to us, we'll publish it. But the concept is the same, that you give transfusion, you increase the iron load, the iron ultimately causes the oxygen radical injury. I'm so sorry I started because, the people were on the Zoom.
The other had to go to the nursery there.
Yeah, that's fine. They are not ready. So now another question. What would be the PaO2 in the radial artery? If you take my blood sample now, what would be the PaO2? 10, 50. Any ideas? If 70 to 90, good, very good, somewhere there. So again, the exact answer was it depends upon where I am. If I'm flying, or if I'm in Denver, I'm in Boston, my altitude. Second thing, how much is oxygen in the atmosphere? If if you are giving 100% oxygen to me, my radial artery PaO2 will be different. And how much is the also basically the whole thing is there are any shunts or not? Depends, exactly, it depends. So on the one side, I have room air. On the other side, I have 100%. So would it make a difference in my PaO2? Now I know yes. And then I will tell you that I will explain. So you got it almost right. And then the other one will be higher. And the reason is this. So see, like it's a busy slide, but the point which I want to make, if you can just take it from this slide, is the higher the oxygen in your lung, and if you have no shunt, most of the things should go still to your lung. I'm so sorry I started because people were on the Zoom, but you will catch up honestly. I will repeat the concept many times. So again, the same slide I'm showing you, and now I'm walking you again. See, same thing. And this is the equation you have to learn, and I will walk you through this equation. They ask you this alveolar, gas equation many times in the exam. So see, now we got. So you just have to know this concept that how from pulmonary vein things go to the left atrium. You guys all know that, but basically the more oxygen you are giving to the lung, and if there is no shunt, I expect at least 70-80% of that oxygen to be going to so that's why what we do in PPHN, if you have a baby, they bring you a gas and you see a PaO2 of 90, great, but the baby is 100% oxygen. So it should be, so older way of doing it was we used to call it hyperoxia test. We don't use it anymore. You give the baby 100% oxygen. If PaO2 goes above 200, you say your cardiac anomalies are ruled out. But now you have ultrasound in your hand. You don't need to do hyperoxia test. And the other reason is oxygen toxicity. Remember the slide which I showed you before. So you don't want to do a hyperoxia test. You have a very handy device. Anyways, this is again a repetition. And this is to show you that we need cell phones almost equivalent to oxygen and a Wi-Fi. So if I'm in Maslow's hierarchy, I will require these three things. So now again, the same thing, like I said, I will repeat it many times just to make sure that you guys get the concept of partial pressure and all that. So again, follow the animation. So the gas comes here, oxygen goes to the alveoli. It is, so there are so many things can happen between your, oxygen in the environment to the time you get delivered to the tissue. Many things can go wrong at any place. So people used to, I was trained in a very hierarchical environment. So a professor used to ask in the round, what is anoxia? What is hypoxia? What is ischemia? What? So you have to tell exactly anoxia is no oxygen, hypoxia is low oxygen. Now, what is ischemia? Ischemia is at the tissue level. I don't think so anybody will ask you that in exam. It's just a conceptual thing. So see another slide, and I promised you that I will walk you through the gas equation. So you guys see in bold here, this is the gas equation. This is very important to know what is in your environment and how much in the alveoli, and from alveoli, how much goes to your system. So we call it an AA gradient. The big A, whenever you see a big A, is alveolar. When you see a small a, that is arterial. So this is the equation, and again, like I said, this slide will be available on for the review later on. But again, the same concept I want to walk you through, that there many things could happen. Like, you have a good ventilation, but you don't have good perfusion. So your alveoli, for example, number one, in this, you see everything is okay, but here you see the other way around. This circulation is happening, but there's no ventilation. So we call it a VQ mismatch. And they do ask you many questions about that. But this slide, basically, I just want to take the concept of gas equation, because gas equation is asked in exam, plus you have to know. And whenever you have a baby who is in PPHN, you can do the oxygenation index and you can do the AAD2 to see if patient qualify for ECMO or not. But that is a different talk some other day. So anyway, so this is what I talked about. Let's see. These are the two board questions. Fortunately, they will not ask. I haven't heard in the last 5 years that they're asking these questions, but when we were preparing the board, these are very, very popular questions. They give you a case that you are sending a baby from Chicago to Boston, and Boston has, the higher altitude, what will be your oxygen you will be sending the baby. So again, you don't have to remember it, but this is the equation you apply. And here also, if somebody you're calculating, you just have to know how to apply.
Here,
Sure.
let them do the math, because that question still.
Or still comes up, I'm sorry.
So remember that the concept of a gradient depends on the atmospheric pressure is going to change. And folks, Colorado, you have a very big hospital. That's the questions. You'll like this question, and they put questions on the board. So remember that the alveolar pressure, you want to find out how much FiO2 you need to give for this, correct? So in Louisiana, it's 716 minus the 47. So, and you multiply that by 0.5, it should equal the same FiO2 times the atmospheric pressure that is now different over there. It's going to be 716 minus the atmospheric pressure is not 47 anymore. It's because it's a higher altitude. So if they give you the 633, so the 633 is what it should be. So you multiply the FiO2 by the product of that pressure, and then should equal so and so. And then you do the math, and it comes up to be a rise like 60%. They don't make it too complicated on the boards because you have a limited time to answer that question. You've got 5 minutes on the mock, or if you're doing it on, in person, it's going to be 90 seconds. So they're not going to give you something too sophisticated. But the easiest way to do it too is just look at the difference. The pressure is, atmospheric pressure is 633. The other way, 760. So is it 10% difference? Close to, so you go up by, 20%. Do the math quickly. 760 minus 633. close. So they give you multiple choices. They give you 55, 50, 45, 21. So you pick the one that is higher. Sometimes you even have to do the math, but that's the quick and dirty way of doing it.
And this is important, honestly, because I don't know. I was told by younger, neonatologists that they're not asking these questions, but it's good to know the concept, honestly. Anybody knows how to remove the bar from the bottom? Like, should I click something or this one? How can I get rid of? Just click it or no, I don't want to. Anyway, okay, it's done. Something I did. Okay, right. Okay, good. So now again, see, previous slide we talk about, I showed you how different things are related. So just making paper out of paper, that was I was doing when I was young. This is 1990. So I came up with this, if there is hypoxia, of course, erythropoietin will be stimulated and you will have nucleated RBC. So I submitted to a journal in the UK and they liked it. Remember, 30 years back, it was very easy to publish. So don't ask, oh, this is nothing, Dr. Manzar. Trust me, at that time, it was something to them because you are creating a new concept that you can do even an AVO2 and you can relate it to the nucleated RBC. On the same token, I was very happy that this was my first full length paper and it was published. So again, it's not advertisement. It's just to show you that how you can just come up with a question and make it to a paper, which, physiological concept. So now this is another thing. Like I told you many times, I will tell you the concept that how the atmospheric air ultimately gets to your tissue level. This is again the depiction of the same concept that in alveoli, then it goes down, it goes down. So somebody asked me that how this oxygen like dissipate from 100, you have 200 in the 150 in the alveoli and only 90 in the radial artery. So let's do the question and see if we can make out that. So this is an infant who is on a ventilator, 35% oxygen, lines are placed, a blood gas is obtained, the PO2 is 92. The respiratory therapist is unsure whether the specimen is obtained from an umbilical venous catheter or an arterial catheter. The true statement is, so look at the X-ray, what it is. First of all, from a PaO2 on the gas, can you make out is it venous or arterial? In the first slide where you put it up, you said, if you give me the PO2, Dr. Mazhar, I can tell you if a uterine artery or if an umbilical vein. And you did it great. So what about this one? Why? Suppose if it's a venous catheter, do you think the PO2 could be 90s? Is it a possibility? A venous catheter can give you a PO2 of 90. There's a trick in this question. Where is the UVC going?
Yes, it can.
Yes, excellent. Good, Sarah. Thank you. Because UVC is crossing the Foreman over. So basically, you're getting the higher PO2. So that was the clue. And the answer was easy. It's a A. Okay. And now this is the
Wasn't
question.
that the old way of
I'm sorry?
knowing if the wasn't that the old way of like knowing if the baby has
Right.
like an ASD or
Right,
not?
right.
Yeah.
Right, exactly. Actually, I remember when I was preparing for my board long back, they gave you different pressures and they said, tell me the course of the catheter. So you have to tell the course of the catheter that is going through here, and now it's in this. So you have to remember the saturation of every area. So now you can say,
Oh, yeah, no.
relax. So this is the thing. See, atmosphere, it started at 160. By the time it reaches contract the mitochondria, you have only 5 PO2. So the analogy which I use is the salary you guys get. Okay. By the time you are finished with your month, your salary is only 5. So call your mom if or somebody that don't ask any money after 25th of the month. You can ask money on 1st of the month. When my alveoli are full with oxygen, then I can get it. Otherwise, everything will be dissipated by the time it reaches 30th of the month. So again, now because any talk of hemoglobin or this whole oxygenation cannot be done without hemoglobin, because hemoglobin, you all remember, it is a tetramer, it carries oxygen, and then these forms are, like I said, I'm not going to touch the basic sciences just to show you, just, really give you brainstorming. And then I want to talk on the practical aspects of it. And again, you have to know the RBC pathway for the exam. They love this pentose phosphate shunt. They ask you question all the time by phrasing it. They will give you G6PD and they ask which enzyme and how it acts, where is the glutathione at. Just revise it. I know it's very volatile. You read it many times. By the time you go for exam, and you just forget it.
I want to just add one more comment,
Sure.
Dr. Manzar. If you go back to the picture you showed.
Previous one.
So what if you have a blood gas? That's another board question. A blood gas from the UBC that is reading a PO2 of 150. What is the differential diagnosis?
Which one? UAC.
From the UBC. It's a congenital heart disease. Now you love that question. why would you have on the venous side an oxygenated blood? How often is that?
I'm sorry, AV malformation?
Not gonna have a congenital heart disease. You have an anomalous pulmonary venous return. Pulmonary arteries coming back to the SVC and the IVC. So your UVC is in the right atrium, you're getting
Got it.
oxygenated blood there. So this is this is a question that's not made up. They just really, I've seen it. So if they put total anomalous TAPVR, total anomalous pulmonary venous return, just use that one. So a UVC, of course, if you have a UVC that's going across the right atrium through the PFO into the left atrium, that would be another reason for having get your chest X-ray you showed and it's going up in the left atrium. But if it's in the right atrium and you're having a high oxygenation, that is, you have to think about total anomalous pulmonary venous
Think of
return.
anomalies. Yeah, good. So now we are back to the meat of the talk. So which of the following you guys think that shifts the curve to the left? Any ideas? Yes. Fetal hemoglobin. Okay. What about alkalosis? What about decreased HGP?
Yes, alkalosis too.
Low temperature. I purposefully put this slide all shifted to the left. And I love mnemonic for the exam. So remember the word low. If you see anything with left, alkalosis. So there we get confused. So remember, otherwise everything low is on the left. So fetal hemoglobin is separate, but if you have low, CO2, you have low temperature, low GSPD, low, whatever is low is on the left. Except for just remember, because the pH is high, it's not low. But if you remember from CO2, you will not, or alkalosis, if you remember the word low. So you will not do wrong at that. But again, the concept is important. For exam is different because you are limited with time. But it's very important the way this shifting occurs. The body is so nice that if there's acidosis happening, there's something body try to release that oxygen fast, so the affinity decreases. See how the body adjusts to the needs in acute atmosphere. So now the question is, why the neonates with hemoglobin of 7 gram per deciliter are usually noted to be tachycardic? Of course, this is a talk about oxygen, so it has to do with something with the oxygen. So I'm giving you some tips already. I see Dr. Mahan has explained it many times in rounds and in morning report. I have seen him doing it, so you guys should get it right.
Bound to the
Tightly bound. What do you think? If hemoglobin is 7, why the baby is tachycardic?
So it's a reflex tachycardia in response to decreased oxygen carrying capacity of the blood, and the heart is now trying to compensate for that decreased capacity by pumping more every minute.
There's an equation to it, and you have to remember these concepts. One is oxygen content, one is oxygen delivery. And for oxygen delivery, you need cardiac output. So if your content goes down, you have to compensate it with something.
Delivery.
Exactly. And the only way you can do either stroke volume or you can increase the heart rate. But Starling curve that once you reach a point, you cannot work on the volume unless you really, so that's why they are tachycardic. Good. And again, this slide is important because it talks about the concept of oxygen content, oxygen delivery. And like I said, this is not the purpose of the talk, but I just want to throw it there so that you know why this is clinically relevant. And again, the concept of saturation in the blood and saturation in the pulse oximeter. I question it to students and always get them wrong so that I can put my point. They're entirely different things. So if you're getting a pulse oximetry, that is different than whatever you get in a gas. That is a calculated value based on the oxygen dissociation curve. Okay, now another question. Why in a neonate with hemoglobin of 6 gram, and this baby is not cyanotic, despite the saturation is showing 975 on the pulse oximeter? You come here, the baby is 7, baby is not cyanotic. You said, what's going on? And we check the hemoglobin is 6. What the hemoglobin has to do with cyanosis? Any ideas?
Because the pulse ox reading is dependent on the hemoglobin, right? So if the hemoglobin is, because let me say this. The pulse oximeter is detecting oxygenated hemoglobin, right? And that's how it's giving us the reading. So if the hemoglobin is low or the cardiac output is low for that matter, the pulse ox reading will be low.
Very close, but I wanted the, how we till you get the right answer. When you're receiving and you're not satisfied. Basic idea is you have to get the clinical cyanosis, you have to have a certain percent or certain gram.
Of deoxyhemoglobin.
Excellent, good. You have to have that, and I'll show you the next slide. So basically, this is the concept. And this again, they ask you in boards, and it's very easy to understand. First of all, like from out of your total hemoglobin, 3 has to go wherever you want. So if you have 6, 3 has to go, become deoxygenated before you see the cyanosis. So if you have already 6, then of course 3 is gone, you have only 3 left, so 50%. And this slide again explains it very well. So just remember, if they ask you an exam, this is the answer Danish was saying. But I think if you combine both, then you get the right answer. So make sure when you take boards, you sit together. You get one question right.
No, so 3 grams per deciliter is, so if a baby has 6 grams per deciliter of hemoglobin, so 3 would always be deoxy?
No, more. Like you have to have, so for example, let's say I have 15 hemoglobin. So if somebody put me this question that at what level I will have cyanosis. So I give 3 already, 3 for my cyanotic clinical, I left with 12. So you divide that, you will get the percentage. So I will be maybe 83% when my saturation will be 83, I will have clinical cyanosis. But if I have anemia, so this is a deceptive thing. I will not manifest cyanosis because I still have this 3 gram to first saturate as a deoxygenator to give me the clinical cyanosis. So something like that. Okay, now, like I said, we are going to talk about the real part of the discussion theory we touched. So oxygen therapy from delivery room to NICU, there are a lot of debates, going with room air resuscitation. And I showed you that how they have included even cardiac module now in the new NRP, which is going to come in November. So I think fellows, you guys should also order one book. I have ordered already. So the resuscitation, the new edition is coming, and they're going to talk about cardiac component, how the oxygen is, differently looked at now. So of course, the indication is desaturation. We all know whenever the baby has, you guys present daily, baby has events. First thing is what they do, tactile stimulation, start oxygen. So desaturation is one thing. Cyanosis is another. The other one is a low PO2. If somebody comes with a gas of 34, and you first thing, how much is oxygen? 21. Increase it. At least let the baby get more oxygen there. Apnea bradycardia is our daily round bread and butter. And then during CPR, and we're going to touch base on that how it differs. And these are the 4 conditions that where you need less, where you need more. PPHN is one condition where nobody will say that, oh, just try to cut back oxygen and you are worried about oxygen critical. I remember I was on call, very junior fellow. I should not be committing my mistakes in front of my junior colleagues, but I have to do that. Somebody called me on a PPHN around 2 a.m. and they said, oh, baby saturating 85 and our cutoff is 89. What should I do? I said, decrease the cutoff to 82. And, so that I will not be bothered or something like that. And it's so laziness on my part. Next day, my attending calls me and she said, Shabi, this was a PPHN case, okay? You want the baby to be saturating 93 and you gave them a cutoff. And thank God it was not electronic at that day. Otherwise, I will be still dinged with that. So she showed me the flow sheet, and it's a really learning curve for me that she showed me that, first of all, look at the case. It was not an ROP or where you want to restrict oxygen. So and then she kind of walked me through. She said, just learn. Whenever nurses call, just go ask them what's really happening. Don't just give them on the phone. Oh, you know what? Yeah, just go back on the monitor and cut back to 82. They will not call you, but the baby was desaturating to 83 all night, and they were not calling anyone because fellow has given them this cutoff, which was totally wrong. Thank God the baby survived, but I was so upset with myself just for a simple laziness, not to really go or not knowing it really cognitively that, PPHN babies should be oxygenated well. Otherwise, they will really deteriorate on your hand and they will die. So anyway, less and more. We all know that how PPD and all that, it's a vicious cycle in the PPD. You don't give oxygen, they have other problems. You give oxygen, they have other problems. And with ROP, we are going to talk about the debate. The other debate is which side of the aisle you are. Certain nurseries follow the low kind of saturation targets. Certain nurseries follow the high target. I think one of our colleagues, I think Dr. Bhatt or somebody covered it in the apnea talk that how some people are really shooting for 89 to 93. The other are going with 87 to 91. So it depends upon our practice. We follow the New England Journal where 89 to 93 is our cutoff. Or again, not for PPHN, please. If somebody call you, PPH is different. So this is again an article which shows how the restricted one and the liberal one are debating it. And this is a nice slide.
There's no debate, just that, because they'll get that question. There's a lawsuit because of that debate, as you all know. There's a paper that's published in the New England Journal of Medicine. It's a support trial by the NICHD. And the NICHD was sued by the families of babies who were enrolled in 85 to 89% arm. And because they had a higher mortality and they had less ROP, whereas the others had lower mortality, means the 91 to 95%. But at least they survived and they had a smidge more of an ROP on the outcome. So if you get that board question, it's settled. It's not debatable anymore. You know, lower SAT is associated with a higher mortality in mature babies. When it go to 90 to 95%, that's what everybody got going to do. The problem with that study, when it was published, many of the families was in the New England Journal of Medicine, randomized control, different 14 different centers. When the family saw that, you took my kid liberally and you did not have your safety monitoring committee halfway through deciding that my baby would die if you continue to deprive them from oxygen, just to prove a point and making a study, they sued. And I think they settled after multiple years, but it was really it's an ethical concern. In defense of the NICHD, the halfway assessment and evaluation did not show a difference. You should have stopped, did not show more harm, but it showed no difference. They should have stopped at the time. But they did not know that the patients would die more. When they finished recruitments, remember, there are 14 different centers. They don't have all the data available like instant. They realized that there was a higher mortality. And I've attended these debates, these ethical concerns, which are all justified, but I'm sorry.
No, you're right, absolutely. And the reason I'm telling you, because fortunately or unfortunately, I have rotated so much in my career. I've got like 17 hospitals, and my wife joked that you have 19 homes you have shifted since we got married. So my kids say that you should be in military anyway. So I worked in these centers where they really strictly follow the restricted guidelines, and you are just a locum tenens person, and you said you're doing wrong thing, but sometimes it's very difficult. And I tell you, the remoter the hospital, you will see funny stuffs happening there. Like I gave example in my grand round that you have the babies saturating 99% on 2 liters cannula because you can build the baby on the IIT. Is it right? No, it's not right. Can I just stop it? Maybe, but I'm getting paid for my shift. I can just say to the neonatologist that, you know what, sir, please, I don't think this is needed. Oh, no, this is the way I do it. But Dr. Mahan is making a very valid point. At one end, you have a baby dying or baby becoming blind. So you should, it's really like we call it as, among patients error, there are 3 categories. One is near miss, one is, adverse event, and last one is sentinel event. So having a baby blind is a sentinel event. You cannot just say, oh, you have a near miss. We followed the restricted guidelines, but see, no damage done. No, its damage is already done. And it's not even an adverse effect. If somebody get a more likelihood of ROP, you have a baby with a stage 4, stage 5 disease. So this is again a busy slide, but again, just to show you, if you guys know Dr. Satya, he has very nice graphic representation. He's an artist, honestly. So if you don't follow him, He really teaches very well with the diagrams. But again, showing the same thing, that how transition happens at birth. And this is a nice slide telling you, the balance between the PPHN on one side, NAC, and the other threshold ROP. And there is a big debate. And then this person I have seen change over the last 30 years. He was pro of one thing, nitric oxide in premature. Now he's not any pro. He said, no. But that's good. You change with time. With evidence, his same thing is changed. Another guy who is Dr. Benton is a PDA. He used to ligate every babies, but after 30 years, he has changed. He's on the other side. He said, don't even treat PDAs. So people adopt basing on the evidence. Anyway, now going back to the delivery room. And this is something fellows must have noticed, that how unfortunately you guys are like pushed behind and you see malpractice. I'll say malpractice. Don't quote it outside this room. How fast they go on oxygen on babies, not following our, the guidelines. And sometimes even if you want to say something, I have, as an attending, I have faced that too. You have to say, don't give oxygen. The baby is 1 minute old. And their first thing is that oxygen. Why? Because baby is setting 82. You still in first minute of life. Are you kidding me? But see, the education has to dissipate all the way to the end user. Our nurses, our RT should be part of the team. But sometimes, they are trained in a very different way. They see the desaturation. It's not an NICU baby with, apnea and bradycardia. It's first 5 minutes of life. They have very different oxygen requirement as compared to later on. So again, like I said, there are studies comparing, room air versus 100%. But now I think most of the people agree that on babies who are preterm, you can start with room air. On a bigger baby, you can start it a little higher. So again, like I said, I put this comparison. You guys can pull the article and put it later on. But I think the consensus now in the NRP is, but this is a good article which I want to spend time there. I think you presented it, or I think you looked into that, and that was a nice thing. And I went back and looked at the article. So basically, they're talking about, using, because now we have an option of delayed cord clamping. We don't have that gadget yet, but in UK, I think you might have seen they have the gadget now. They can roll that card to the perineum of the mother. So baby is delivered on that card, not on the warmer. So the cord is still attached. So you can do whatever step. We can replicate it, unfortunately, because we don't have that thing. If you guys see, our room is entirely a different room. So you have to have a cord which is like a tennis cord or something, which I don't think so. Moms can make that cord to have a baby attached to the placenta. Anyway, the idea is this is a very interesting study, it's a randomized controlled trial, and they talk about that using 100% oxygen is basically going to reduce the hypoxemia without increasing. So this is like Dr. Mahana said, in neonatology, we do something, we make expert in that, then somebody question it, then we go the other way, then pendulum swings the other way. It's a lot of ifs and buts. Like recently now, there is an article debating now that dopamine is better than epinephrine. We changed our practice, and last year we all went from dopamine to epinephrine. Now they're saying dopamine is actually much better than. Help me, sir. I'm going to retire, so don't make all bad. So this is very important slide. And like I said, if we talk to the nurses and just give some time, I had this other day too. So the easy mnemonic to remember, 1 minute has 60 seconds. So just remember that every minute it changes by 5%. So if you're telling your junior, just say that, 1 minute, if it's 60, you are okay. Okay. For every minute, just add 5% to it. Can you do that? If they can do that, then they know by 10 minutes, 85 is okay. You don't have to give oxygen. But again, now, like I said, evidence is changing with time. The new research is saying that it's not only hyperoxia, it depends upon what dynamics you have. If the cord is still attached, you have a very different hemodynamics happening to the baby as compared to if cord is clamped. And again, remember, oxygen is a drug. Just have this notion passed to your nurses, especially that, you don't have to just put on oxygen after birth. It's entirely different dynamics that a baby is making. And like I said, the new book is coming, and you guys know better than me all these memes, so I don't want to stay much time on that. So watch out for that thing. Now we have talked about delivery. So we talked about from room air to 30%. How can our main aim, if you take it from this thing, please, if you can take it to the delivery room and tell them not to be first 5 minutes, just be kind and nice to babies who are 34 and above and termish kind of. If a baby is small and of course you're intubating, you're doing cardiac compression, of course 100% oxygen, no question about that. But it's difficult. Can I do that honestly? I'll be very honest with you. No, it's very difficult. They will put this thing to my hand. It's very difficult to unless they buy the physiology of it. And that's unfortunately still I see the dichotomy between nurses and MD program. I think we are very much into physiology and they are very much into practice side of it. So, and we clashes because their practice is desaturation, oxygen. Our practice is calm down, look at the pathology, what's going on, which we talked about in our earlier presentation. So this is the article I think Dr. Mahana was referring to that finally, they looked at it up and I don't have to reinvent the wheel, but talked about it. Again, the same slide I showed you. So now targets, once you agree, like we agree, anything, less than 90, we will not buy it. So this should be our target. Based on that, what they call it like a old protocol, oxygen with love. So they put it on. So basically you follow that and you make sure that, like I have seen sometimes some practitioners are so good. They see the baby's saturating like 95. They tell the nurse, well, how come the outputting? Oh yeah, I was about to turn. The baby just has suction. No, just don't go on Facebook. Just do this thing. So there is a solution now. You can have an automated system. Like instead of having nurses watch this saturation and then act and go back, we can have an automated system, just like our thermostat. You don't go every 1 hour and change your temperature. So it's also they come up with this automated system, but unfortunately, like I said in medicine, before getting a machine to practice, there are a lot of things you have to do, get an approval, FDA, and the company which was doing got sued already. Like Dr. Mahana said, there was so much complications in those babies who are on the study arm that they have to fight the sue first before even they can go to the FDA to get it. But the concept was very nice that if we have an automated machine, the machine detects there is a desaturation and pumps more oxygen. This could be done, and they call it as something automated, something I don't remember, but
Closed loop validation.
yeah, close exactly.
Dr. Bancalari. is
Bancalari,
the one who
exactly.
made a lot of work.
I think this is the probably study, but I think I looked at it. So now there are certain uses of oxygen beyond only 2 slides, just to complete my presentation. One is giving mother some oxygen. And like I said, when you're preparing for your boards, there are certain questions which are in market, like for example, ADO2. So when we were fellows going for exam, there was one thing that moms who do Lamazi exercises, what is going to be the PO2 of the baby? So it's an exercise like a yoga thing where mom takes deep breaths. So basic concept was that if mom's CO2 goes down, what will happen to baby's pH? And they give this question in the board. Thank God I haven't heard in last year these type of questions are asked. But the concept is again going back to slide number 1. If you remember how arterial PO2 and all that. So remember, any change in mom gases situation, of course, will change baby's situation. So whatever they're giving you, if they're giving you a mom is practicing an exercise, a new exercise, a new yoga come where she has to hyperventilate, then of course she has that low CO2. So just apply that into practice. These questions I see that we miss it because we think it's difficult. Just like I showed you P50. Then now if you get a question on P50, you said, I will do it right. And you send me a cigar or a whole thing on when you pass your boards. Okay. The Dr. Manzar, we got that one right. Okay. And again, another one that what is the role of oxygen, in our beds? We talked about anesthesia complication and all that. So in conclusion, so first is oxygen is a drug. So please be aware about this, the oxidative stresses. See whenever you can, if you have control, if you see the baby setting 95 and above, it's not PPHN or something, it's a feeder or something. So please increase the oxygen if possible. Tell them many nurses are very cognizant, some are not. Junior nurses, just talk to them in a softer way and say that, don't you think so that it will cause ROP or something like that? Then of course, keep a balance between hypoxia and hypoxia. There is a fine line, when to do, when not to do. And oxygen is not only the controversy, even blood transfusion is a controversy. Like some people say, oh, I will be okay with 11 hemoglobin. The other attending walks in, oh, why didn't transfuse the baby? Because Dr. Manzar said not to do it, or he and she said not to do it. So again, depending upon which fellowship program you are trained, some are restrictive, some are liberal. It's a debate. So if you do a lot of locums, just go there, follow whatever they're doing, and then come back home and do whatever is the right thing to do. The third one is that in delivery room, we all agree that the bigger babies, you could be more liberal, but smaller babies, just make sure you're 21%. And then, of course, follow the NRP table. I think they have posted this thing on all the what do you call resuscitator. Am I right? Do they have this thing oxygen posted on there? Oh, good. Okay, good. So that's what the best practice is. You can post it. You can buy these ready-made cards from NRP. I did buy one, put it there. After 2 days, they removed it. They said it is not sterile because it's not plastic coated. So you have written, yeah, it was $35 pasted. I thought that I will be remembered with my name there. And then after 2 days, it was gone. So don't donate to the cause which is not showing your name. So NMK, again, remember that when oxygen is needed, it's needed. So it's not like, oh, I only want 30% babies having CPR. Come on, are you kidding me? Give them 100% oxygen. And then, of course, like I talked about, that we are shying away from the restrictive side. I think most of us do practice the higher end of the, because like Dr. Mahana said, we can live with BPD a little bit later on, but we don't want blind kids. So simple deal if you want to really take it that way. And of course, automation there's a future there. If you guys end up with a program which follows that, if you end up with Miami, Dr. Kalari, maybe you never know. Okay, and again, thanks to all these resources. I'm a very pictorial learner, so I don't write much, but I take these images and copy paste it. And if you guys know, I have a website, and this was an old presentation, but I have crossed 350 subscribers. I'm so happy, and my views today were